we will be talking about in the next minutes is vascular treatment of ruptured aneurysm. It's a huge argument. So we will to have some messages about the treatment, which is the major part of my job since many years. First of all, a little bit of history about the aneurysm that, as you may know, our field of medicine is a small field that have been evolving very quickly in the last 40. Evolution has been very, very quick in the last few years. So we are still going very fast, and the technique and also the pathologies that we can treat are, let's say, rapidly changing compared to other branches of medicine. So we've come a long way, and we start from the 60s or the 70s, in which we used we is not we, because it was my teachers and also the teachers of my teachers that started treating aneurysms with the so-called detachable balloons, just putting a balloon inside the sac by the endovascular route and then detaching them. Here you can see Dr. Serbinenko from Russia that first invented and managed this kind of endovascular approach. There were basically latex balloons of different shape and diameters that were that could fit different size and shapes of aneurysms and forever. That was a very, let's say, primitive technology. So we go immediately to this case. I will show you a lot of cases because in my mind, the idea of going through real-world cases is a good way of learning things. This is a lady of 71 years old with a progressive visual impairment, for which she undergoes a CT, and this is what we see, a huge mass, slightly hyperdense in this region, which is a suprasellar region or base of the frontal lobe region, which is obviously a large aneurysm. At this time, we were at the beginning of the 2000 century, and this is the MR and the geography. Very big aneurysm that is basically going to compress the optic chiasm and giving a impairment of the right eye, but initially also of the left side, for it's going beyond the midline. So there's an indication for treatment, both for compression and also for the risk of hemorrhage. This is an intradural lesion, so a hemorrhage would be a subarachnoid hemorrhage. So what we do, we study the contralateral internal carotid artery, and you can see here the how is modified the A1 segment of the contralateral anterior cerebral artery. It's basically going up because of this sac, which is here. And what we do is see how the right hemisphere is vascularized so that we can understand what we can do for this lady. This is a manual compression of the right carotid artery while injecting the left side. And as you can see, there's a passage which is a good cross-filling through the anterior communicating artery, which is a good thing. Why is a good thing? This is the lateral, because we can occlude the artery with this balloon. There were not the latex balloon of the Serbinenko era, but these are newer latex balloon, but the concept is exactly the same. We can put this latex balloon very close to the aneurysm, but proximal to it, so we don't need to go through all the internal carotid to the brain. We inflate a balloon without detaching. We do other series and see that the collateral flow is very good. So we detach the first balloon and we place another balloon proximal. And this is the final result in the follow-up. Here is before, and this is some months after. In upper row, you see the aneurysm, and this is the control, and the patient is going very well. So this is the treatment of aneurysm by parent vessel occlusion, which was very common years ago, and now less and less. Why? And this is why I ask, would we do the same thing today? Probably not, because the evolution is bringing us in another direction. But just to remember that parent vessel occlusion is still a very good way to treat this giant aneurysm when feasible. Evolution has been incredible over the last year. So let's point out some principles. Why do we treat cerebral aneurysm? And the aim of the procedure is different, whether we are talking about ruptured or unruptured aneurysm. For the ruptured aneurysm, we want to protect the patient from rebleeding. So the effect of our treatment is measured in days, weeks. More important is the protection within months or years. So we want to save the life of the patient, and we have to do it in an emergency setting, and we have to protect it for weeks, let's say. Then once the patient is out of the acute phase, then we can talk about how we can manage better compared to what we did in the acute phase. Is different from the unruptured. The unruptured aneurysm needs a protection from the first bleeding. So we have to protect it forever, hopefully. Or we have to reduce the mass effect, as we saw for Ornella, the patient that I showed you before. So the aim of the procedure, whatever the setting, is a clinical result, not only for the images that often do not really correlate with the clinical condition of the patient. Another concept that I like to show every time is that we have two very great revolutions over the last 30 years. One is the intrasaccular, what once were called the GDCs, the Guglielmi detachable coils, platinum coils that we place in the aneurysms, coils, and then all these approaches that are based on coiling, and we will see that later. Just to give you an example, this is a SAH, subarachnoid, you see blood here and in the cystins of the skull base. Valeria is a 30-year-old lady. She had this hemorrhage, and this is her aneurysm here, tip of the basilar, with this that we call a small bled, which is probably the hole in the artery that bled. So what can we do? We go up with an aneurysm, with a microcatheter, sorry, in the aneurysmal sac, and we place these coils, 1, 2, 3, what is needed, and we occlude it. This was done the first time in the early 90s of the last century, and is still our gold standard for ruptured aneurysms. This is the final result. The aneurysm is occluded, as you can see. This is before and after. 6 months follow-up, still okay. There's a small prolapse of this loop of the coil inside the vessel, but it's of no importance. Sorry. Okay. Please interrupt me, whatever is happening, or if you don't understand, or if I can complete, or if you don't see perfectly the images. So 6 months, 6 months follow-up, another projection, and this is the 3.5 years follow-up with the angio-MR. As you can see here, no more aneurysm, and this is the 7 years follow-up, and it's perfect. So this is an old approach, very effective, and still, as I said, the gold standard. Another patient, young patient with an acute third cranial nerve palsy, basically diplopia, acute diplopia, which is typical of posterior communicating artery aneurysms like this one, that has a big bleb, which is basically a small hemorrhage here down the sac, is running the third nerve. So this small bleeding is against the third nerve. And this is why this case is treated as an emergency case, even if the subarachnoid hemorrhage is not a huge hemorrhage. But this is considered a pre-rupture. So we go quickly and we do more or less the same. As you can see, this was years ago. Same platinum coils inside the sac. 6 months follow-up, there's a kind of perfusion of the proximal part of the aneurysm. And this is 1.5 years after. The recanalization is a little bit more evident. Should we do something? We said no. And this is the 5 years follow-up. Patient is fine, no more diplopia. And this kind of recanalization, which is typical of the coil embolization of the aneurysm, is stable. We know it, we leave it there, there is no evolution, and the patient is cured. So 6 months, 5 years is basically stable. But as I said, the evolution has been incredible. So today, for the same aneurysm, we have a lot of options. These are all the tools that we have on our shelves now. Some of them are very popular. Some have been forgotten over the years. And these solutions are honestly too many. Why? Why there was a huge production of, let's say, competitors of the coils? Is it because we need additional devices or additional approaches, so coils are not enough? No, no. We have some recurrences, as you could see, but the real rebleedings are very few. Do we have few rebleedings because we retreat the aneurysm before they bleed again? No, no, I don't think so. The reason is another one. The reason is the idea and the desire that we have to basically stop doing follow-ups and to have the possibility to tell the patient you are cured, you are not a patient anymore, you don't need any additional follow-up in your life. So to have a very stable result. So because of that, because certain kind of recommendation, we, meaning the companies, produced some additional devices. But this is much more, makes more sense for unruptured, because as I said, for unruptured aneurysm, we want to have a good result forever. So for unruptured aneurysm, additional devices or some devices that has replaced the coil embolization has been using more and more, much less in the emergency setting. Even in the emergency setting, that is for ruptured aneurysm, we have to push our technique. This is a kind of triangular ruptured aneurysm, not really easy for coil embolization. We should need some different devices? Yes and no. In this case, we use just a couple of microcatheter, both inside the sac. We deploy the first coil without detaching it, and with the second microcatheter, we put other coils inside the first one, and everything is stable, and this technique allows us to have a good feeling of the sac. As you can see, this is end of treatment. This is 6 months follow-up. It's basically a different type of approach, but the same using coils. And this is the 3 years follow-up. Same thing, but slightly different. In this case, anterior communicating aneurysm, you see there's an artery going in here, and another one going out here. So the neck of the aneurysm is very large. So in this case, this is a 3D reconstruction of the aneurysm. In this case, we have to invent something different. And what we do, which is as well a routine way of treating a large neck aneurysm, we use the balloon. The balloon is placed in the sac, at the neck of the sac, and is inflated, as you can see here, while we deploy coils. So because of thanks to this technique, we can have a good feeling for this neck aneurysm. And this is another case, 66 years old women. This is the bleeding. There's a good, let's say, medium-sized hemorrhage because of this, or due to this basilar tip aneurysm, and there's another small aneurysm here. The problem is that, as you can see, there's a broad aneurysm, there's a broad neck here. The basilar tip, the basilar is going in the sac here and is going out in another position. So all this is the neck of the aneurysm. What can we do here? We place a first coil, but you see it prolapses in the vessel, in the parent vessel, and we don't want to occlude this artery. So again, we place a balloon, and while we inflate the balloon, we deployed coils. And this is what we obtain, good filling with the coils, with a good cast, and still patency of the parent artery. And this is it. And this is the angio control at 10 days. So this is a very good result. But again, this is a ACOM aneurysm. How is the neck of the aneurysm? Not really small, but not that big. So this is the neck, this is the sac, the dome. What can we do? As usual, we first try just with coils, with nothing else, and it works. As you can see, this is the final result, patency of the 2A2 segment of the anterior cerebral arteries and occlusion of the aneurysm. This is another case, a huge aneurysm at the angle A1, A2 of the anterior cerebral artery on the right side. Again, should we need other devices? Should we need a balloon? Maybe, but first we try with nothing. We keep it simple because it's emergency, and we obtain a good result as well, even in this case. And this is an extremely difficult case because the aneurysm here is this shape, so all this is the neck of the aneurysm. So what can we do in this case? There's no other way than protecting the neck by placing a couple of stents. So it's probably, we didn't even try to place coils with no adjunctive devices. So as you can see here, we place one stent here and one stent here. This is the so-called Y-stenting technique. Through the stent, we bring the tip of the microcatheter inside the sac, and we fill it with coils. So you can see the unsubtracted. This is the lateral, the two stents, and the aneurysm that is filled with coils. This is the 14 months control. Everything is patent, and the aneurysm is occluded, and you can see the nice cast of the coils. Again, this is just post-treatment, and this is more than a year after treatment, 14 months follow-up. So we go a little bit further. This is a 47-year-old male with an SAH because of the supraclinoid aneurysm that we filled with coils. We are in an acute setting. We keep it simple. We go for simple coiling, but we know that it will recanalize because in this position, the probability of seeing this aneurysm recanalized over the month is very high. But we protect it in the acute phase, and then we see what happens in the follow-up. This is the control after the procedure. At 6 months, as predictable, we have all this part that is recanalization. So what we do, what can we do? We can fill with other coils, but probably it's just taking additional time, but sooner or later it will recanalize as well. So we use another kind of stent, a flow diverter, which is basically a stent with a dense mesh that has the ability and the capacity of diverting the flow, not inside the sac, but in the parent artery. So we will talk about that. This is after the flow diversion, as you can see, 6 months after, no more recanalization, and also the cast of the coils has gone down towards the artery because there is no recanalized aneurysm in between the artery and the cast. And this is, as you can see, there is nothing here, just the thrombus. And this is before everything, and this is after the stage treatment, as you can see. Another similar case, similar aneurysm, bigger. We go for immediate coiling, but we know that we will have recanalization over time. And 4 months later, we go for flow diversion as well. And this is the 6 months follow-up. Again, no more recanalization. Here is the flow diverter in position, and the patient is cured. And this is the MR at 6 months, and this is the MR at 2 years. So we wrote a paper about that, with meaning a staged procedure, coiling in the acute phase and flow diverting the artery in, let's say, later on. The advantage being that I don't have to use antiplatelet therapy, which is a necessity for stents. I don't have to use it in the acute phase when I have a hemorrhage, but I can do the antiplatelet therapy later on in a more, let's say, chronic situation. What can we add? We very rarely treat aneurysms smaller, unruptured aneurysms, smaller than, let's say, 7 to 8 millimeters in diameter. So it means that our unruptured aneurysms are relatively large with a large neck. So simple coiling is very rare in this unruptured and relatively large aneurysm. This is one of the few cases in which we have treated an aneurysm which is not that big, unruptured, even if we have a regular shape and what we call a bleb in the right side of the wall of the aneurysm. So we go in, but we place a balloon because we were scared of occluding this vessel. So we place a balloon and we coiled it, even if this is an unruptured aneurysm. But apart from these few cases, most of our cases of unruptured aneurysm are treated with flow diverters, which is the second big revolution of the aneurysm treatment in the last 30 years, the flow diversion. As I said, most of the difficult cases are now feasible thanks to this new technique, with a real few recanalizations over time. So we obtain one of the aim of the treatment of unruptured aneurysm, the advantage of saying to the patient, man or women, you are cured. We will do a follow-up at 6 months or 1 year, and then it's over. And you are cured, and you are not a patient anymore. These are the flow diverter stents. They are not stents, but I mean, for analogy, they are called flow diverter stents, a dense mesh that diverts the flow. And these are the images of aneurysm that we have been treating over the last 15 years. The nice thing is that you don't have to enter the sac of the aneurysm. You just stay in the parent vessel. It occludes, thrombose over time, and you don't even see the flow diverter. Where is the flow diverter? It's here, but you don't see it. Same here, ACOM aneurysm, follow up, you don't even see the flow diverter. Same for this basilar tip aneurysm. One case above all, this is just to show you how powerful are these stents. This is a 11 years old a girl who had basically an acute hemiparesis and a small ischemic nuclear area, as you can see here. We can see here what is reasonably a sac of an aneurysm in the MR, as you can see here, and as you can see here in the MRA image. This is the CT. The neurosurgeon, she was referred us from another hospital, which is very far away. So the surgeon tried to operate on, but he stopped because he couldn't reach the aneurysm, and he thought that he couldn't manage it surgically. So this is the post-surgical CT, and then the girl was referred to us. We do an angiography, and this is an awful dissecting aneurysm of the left MCA. What can we do here? Difficult. This is basically sac without a proper wall, as all the dissecting aneurysm. This is the lateral view. So we go up with the microcatheter, we pass by the aneurysm, we go further on with the guide wire and with the microcatheter, and we deploy this flow diverter. And this is the flow diverter CTA at 2 months. Everything is thrombose. This is before, and this is the angio at 6 months. And the patient is really fine. This was many years ago, let's say at least 10 or 15 years ago. Patient is grown up now. He's attending the university in his city. These are other examples, supraclinoid aneurysm before and after. Here you can see in transparency the flow diverter stent. We can treat a small aneurysm. We can treat medium-sized aneurysm, as you can see here, before and after. And we can treat large aneurysm. This site is our preferred site, the paraclinoid or supraclinoid. And here you often have also mirror aneurysm on both sides. This is a 53-year-old lady with loss of vision as the first patient that I showed you. And here is one was treated just with flow diverter, the other one with flow diverter and coils, before and after, and the patient is cured. So deployment of this stent looks easy and easier and easier as the technology bring us new devices, but still we have to pay attention to a good deployment, meaning that the stent is well opposed to the vessel wall so that he really can work as a diverter. We need a correct antiplatelet therapy, meaning a dual antiplatelet therapy, aspirin and cyclopidine, aspirin and clopidogrel, aspirin and something else. And also we have to be sure that at the follow-ups, the sac is shrinking. If the sac shrinks, then the aneurysm will disappear. So what about the future? A quick view of possible evolution. Some are real, some are coming up. What will be the future? New intrasaccular devices, new coils, surface-modified flow diverters, or surface-modified stents in general, and maybe some kind of surgery also. These are the Trenza coils, kind of mix between coils and flow diverter technology, so ribbon-like coils that we place intrasaccular so that we fill the aneurysm, but we have this ribbon that are covering the neck of the aneurysm so that the blood is not coming in anymore. This is a case, basilar, tip of the carotid aneurysm. This is the 3D reconstruction. As you can see, we go up with the coil that is slightly more stiff or more rigid than a conventional coil. We place it at the inside the neck, all inside the neck. In this shape, we must pay attention to placing some loops crossing the neck. And then after that, we place regular coils inside. I'm going fast. So inside the first one, you place the other one. You see the transparency is different. And we go on by filling it with other coils. And this is the final result. We have some stagnation of the contrast outside the first cast, but everything looked nice. And this is the 9-month follow-up. And the result is really nice. No recanalization. Is that the future? Maybe for some aneurysm, that could be a good solution. Maybe even in the acute phase. This is another possible solution for the future, but that actually is already being used, is the web. This is a large MCA aneurysm. We place this intrasaccular device whose appearance you can see here is a kind of cylinder that you size depending on the size of the aneurysm. You place inside and you detach. This is the size that is slightly adapting to the size and the shape of the aneurysm. Here is deployed. And this is the 6 months follow-up. There's a little bit of recanalization, but that's predictable. It's not worrying at the size, at the neck, but the rest of the sac is completely occluded. This is treatment. This is 6 months follow-up. One more possible device for the treatment of aneurysm. This is an MCA aneurysm like the other one, but on the right side. This is a device I call a contour size. It's kind of a cup that you place at the neck of the aneurysm, just in this position, so that you can prevent blood from entering the sac. So you are sealing somehow the neck of the aneurysm, and you can detach it, and this is it. It works over time, over the weeks, just by making it difficult for the blood to get into the sac. And this is a flow diverter with the surface modified, meaning that one of the direction of the research of the company is to create flow diverter that had a low thrombophilic power, so that hopefully in the future we will be able to reduce our antiplatelet therapy. And this is one for all the other, that so-called FredX from Microvention. And basically these stents are exactly the same, but they have a, let's say, a resistance to the aggregation of the platelet on their surface. Just for you to know, this is a research, so for the time being, we are still doing double antiplatelet therapy in case of flow diversion. And this is another huge aneurysm of the right carotid. What can we do in this case? This is a surgical bypass. So we ask the surgeon to bypass the MCA, as you can see here. And after that is a bypass assisted occlusion, if we can say that. And after that, by the endovascular route, we fill the aneurysm with coil, and we occlude the internal carotid artery. This is something that we like very much, to work together with the neurosurgeon. And this is a very effective therapy because it's forever. Once the bypass works, you can safely occlude the ICA, and it's done. The patient, you do a 6 months or 1 year follow-up, and if everything is fine, it's the patient is not a patient anymore. And that's all. I hope to have given you an overview of the possibility of treating aneurysm by the endovascular route. I apologize if I have been too technical or maybe too basic. I don't know what kind of specialist you are, so I try to, cover both aspects of the aneurysm treatment, meaning the indication and also the technical way of treating it.